So my name, as mentioned, is Meg Hamilton. I'm a sergeant with Madison Police, and I feel incredibly lucky that the last 3 years I've been able to be part of this Pathways to Recovery grant. I'm not one of the people, a part of the team who's out in the field doing the work, so I'm going to try to dedicate as much time as possible to the practitioners, the team members who make up the addiction resource team so that they can speak from their own lens and their own agencies about the work that we're doing and the spaces that we're trying to get into. But for a few minutes at the beginning, I'm just going to provide kind of a foundation for the work that we're doing, where and when the grant was awarded to us, and the different pathways that make up our Pathways to Recovery. And forgive me, I'm just trying to advance our slide and struggling for a moment.
You should be able to just click on the PowerPoint itself. Yep.
Thank you. I got the options at the bottom of the screen. So just a bit about our grant. The grant that we're operating under, as mentioned, it is a federal grant and it's through the Bureau of Justice Assistance. It was initially a 3-year grant, but as you probably noted with the timing, we were awarded this in 2019 with the intent of standing it up in 2020. Enormous complexities in 2020, not only with our own agency, but many of our partners, trying to allocate the staffing and the managerial time to get it set up. As a result of that, we asked for and were granted an extension to this initially 3-year grant. So we're going to have it until September 30th of now this year. So the vision of Pathways to Recovery was really to expand upon a program that MPD had initially started in 2017, what we call MARI 1.0. And MARI 1.0 had an officer that was dedicated half-time to overseeing a criminal diversion program. What MPD discovered in that first MARI was that there was a need to have some field capacity, to have the officer be able to go out and do follow-up, to try to contact people, because it can be tremendously difficult to connect with people who are in active addiction by phone or by text or via a pre-scheduled meeting. So in addition to allocating more officer time, the vision was also to partner with the agencies that you see on the screen to have a quick response team type model go out in the field to do not only diversion work toward the MARI criminal diversion program, but also deflection work, trying to contact people who have not been charged with anything and steer them toward recovery resources. I did put our guiding principles up here because they're incredibly important to us and we speak of them often, that being person-centered and voluntariness. So there's always someone in an audience that says, what does your grant mean? So I did put up on the screen the COSAP grant, what it actually means, Comprehensive Opioid Stimulant and Substance Abuse Program, and then a little bit about the COSAP program. So the audiences that we get to speak to often want to know, well, how does that translate? What do you mean by all of that? And what our grant has really focused upon is 4 distinct pathways trying to connect people in active addiction toward recovery resources in the community. The first one is the criminal diversion program, MARI, and I'm going to let the addiction resource officer who's with me talk about that one. The second facet is the addiction resource team, which is a police officer, a community paramedic, and a peer specialist from Safe Communities. The third pathway is self-referral, meaning that the team has a dedicated phone number and voice mailbox in which people can reach out to us. Sometimes it's people themselves who have fallen into addiction. Other times it's family members and loved ones looking for resources and a connection point. And then the fourth aspect of our grant is naloxone distribution for people who the addiction resource team visits and for people who are participants in the MARI diversion program. So I'm going to literally shift my screen so that you can see Officer Tom Coyne, and he's going to start by talking a bit about MARI. The breadth of the presentation is going to be about Addiction Resource Team, but we wanted you all to be aware of the program we have in place as well.
Hi there, as Sergeant Hamilton said, I'm Tom Coyne. I've been police officer here for the city of Madison since 2013, and I'm in my second year as an assignment as the Addiction Resource Officer. So kind of MARI program coordinator, and then a member of the addiction resource team that goes out into the community. And as you can see on the slide, MARI is basically like a pre-arrest or criminal diversion program. And there's some other really good programs in the county as well, or in the area. One of the things that's kind of a staple for Mari, for me, is it just shows that we're getting to a better place. I remember being assigned to our patrol services bureau, and you would frequently find yourself in a situation where a person had experienced an overdose. You do a criminal investigation. There's probable cause for a possession of or some other similar charge, and you had pretty limited options about what you could offer to people. It was a lot of times it was a trip to jail was basically the end point you were going to arrive at. Mari, the idea behind it being the criminal investigation goes ahead as planned, or law enforcement fills their statutory role with that by investigating, deciding if there's probable cause or not. But for eligible individuals, there's the opportunity to do 6 months of treatment and recovery support instead of criminal charges going ahead. And basically the way it works is if a person's eligible and willing to participate, they set up an assessment through program partners at Tellurian. They map out 6 months of what a treatment and recovery course is going to look like for that individual. And the charges sit in a folder at my desk for that time period. And then when people are successful in completing the program, they get a copy of those original charges back. They get a letter from our chief of police or the Dane County Sheriff, or the two law enforcement partners in this program at this time, just acknowledging that accomplishment. The other thing that I think is important, and sometimes we fail to mention, but just those charges never go into CCAP. So there's not like an initial person charged with, which starts to affect other layers of your life too, like housing status or other things like that might factor in. So I look at it as Mari is making an effort here through Madison Police, Dane County Sheriff, as we wait for some of those structural changes that may come in statute later. This has given us in the law enforcement community some options to provide people with alternatives to what the traditional criminal justice system has been. To look at the numbers, and as you can see at the bottom there, September 1 through November 30th is where we pulled these numbers from. We are fortunate in the sense that we have great support from UW-Madison Population Health, Janae and Aaron, that help us out a ton. And then we have a data analyst who you'll meet at some point in this presentation, Kaylee Krimmer, who is here in-house with us too. So we can kind of take a look at numbers. And it also is a good kind of active look into, are there segments of our population that we're missing? So just 62 people came in as eligible during that time period. 53 were eligible referrals that were admitted into the program, and you'll see about 26 of those people have successfully completed. The other kind of asterisk by it should be some of those folks are still in, as it's a 6-month treatment window. So there will be hopefully more successful numbers to tack on the end of that as they complete that 6-month course of treatment and recovery support. So Mari, big on the deflection aspect of it. The other thing that we found is incredibly helpful for people in the community is the addiction resource team. You'll meet community paramedic Seth Sanders, and then one of our peers, Lana Hamilton from Safe Communities, just texted me. She was trying to log in, so hopefully we'll see her pop up on here at some point too. And then myself was the third member of that team. But we found even when our patrol services officers were giving really good information about a Mari referral or what there is for resource in the community, people have just experienced a pretty big traumatic event in their life. They might not retain all that information. We just have found extreme value in going back out as the addiction resource team to try and contact individuals who are in active addiction. If they're Mari eligible, make that connection for them. If it's not a Mari situation, trying to just make them aware of what's out there for resource in the community. The grant allows for leave behind naloxone, which has been great too. And sometimes that's as far as that conversation goes for us. People might not want to have a deeper dive into what's going on, but they might take a box of Narcan from us. And we look at that as a success in the sense that we're getting more naloxone out there in the community. We're letting people know, here are some faces that care and want to help you get connected with what support there might be. Kind of our, I guess, just the nuts and bolts of how do we identify folks to try and do this active outreach to. We function in some capacity under a quick response model, but more of our visits come from, there's an algorithm that pulls police and fire data from computer-aided dispatch. That'll go through the data analyst. We'll pull stuff out that looks like it's relevant for opioid, or just other relevant areas for the addiction resource team to stop out with too. Also, and I won't talk a whole lot about it, I'll leave it to Seth, but the patient care checkbox for Madison Fire runs too. So we'll compile from those different data sources, some refinement from the data analyst. Then we'll go out and try and locate people in the community. And a lot of times that visit will look like a knock on the door, or it's been a stop out at a tent, or whatever that location is where we think we're going to come in contact with that individual. Quite frequently, it looks something like somebody opens the door and there's a look of surprise, and we lead with nobody's in trouble. We're a resource team through the city, and then kind of introduce ourselves and go from there. And we do let people drive that contact, where if folks don't want to talk to us, that's their right. They can say, no, I'm not interested. Have a nice day, whatever that's going to look like too. And we can walk away at that point. So we do try to keep it person-centered and person first. So we can provide information about resource, but not try and force it on anybody if they don't want to have that conversation.
And I just want to make a quick note on this slide. The phone number that we have up listed under self-referral, this is a community number. So if there's anyone on this call that's interested in retaining that or passing it on to people, we would welcome that. So I know Tom talked a little bit already about his role, and I'll hand the baton back over to him. Just one thing that I really want to highlight, and is often surprising when we talk to police audiences and non-police audiences, is that third bullet point. Tom does not do enforcement. He does not go out and contact people, write them tickets, take them to jail. And that's very intentional on our part at MPD. We are highly aware that if Tom were to go out and have to arrest someone because we failed to plan in advance for contingency options, that is going to spread like wildfire and is going to have a huge adverse impact on us being able to serve the population we're trying to serve. Or as Tom often puts it, if he comes to your door and says, hey, I'm here to help, but in fact you have a warrant and I'm taking you to jail, we're not at all being true to this programmatically or the spirit of what we're trying to do. So I just wanted to highlight that specific piece because it is often surprising, and it's quite unusual for a police department.
Yeah. And one of the things you'll even see where that bullet point describes that the three of us go out in an unmarked minivan. And what we're trying to do is create that connection or follow-up resource visit without potentially what that first contact looked like. If it's an active overdose and you're going to have fire department, police department, people potentially coming in, lights and sirens, we don't want to recreate that as we come out as your follow-up element too. So we try and keep it pretty low key with our arrival. And it's just, through my eyes, incredibly important too for there to be that differentiation between, hey, we're here to ask you what you need, as opposed to, hey, you have this warrant to take care of too. And it was conversation for team members as we started to get out in the field too, just that idea of how do we build some trust and credibility. And I think that's a major component of it too, is to let people know there is no gotcha associated with this. It's a matter of, if you'd like some of this information in a lock zone or whatever else we can provide, that's what we're in it for. And I think we started to build some of that credibility. It's been nice too, working with the partners at Safe Communities, where I would say that there was maybe a little bit of kind of question coming into that too, is to say you're going to bring a uniformed police officer, a uniformed paramedic, to basically cold call at people's doors. How do you think that's going to go over? And we're like, well, we're not exactly sure. We're going to get out there and try our best to make it positive interactions. And I think we've started to see some feedback that those are positive interactions from people in the community, and that feedback's coming through our partners at Safe Community and then working our way back to us as well. I don't know did Lana get a chance to pop up on here just yet? Are you out there, Lana?
Yes, I'm here.
Do you want to jump in?
Unless we can have Seth first.
You bet, Lana.
There we go. All right. Yep. So obviously, Madison Fire Department is very interested in a program like this. Clearly, on a daily basis, we deal with the aftermath of overdose and the results that families have to deal with. So community paramedicine is a newer thing, and it kind of is a program that fits to the need of any environment that it's in. For example, in South Dakota, maybe someone does stitches because traveling 4 hours to a hospital seems rather ridiculous. So we would have the ability to do that out there. In the cities, it's morphed into a different thing where you've probably heard of the CARES team. That's the most well-known use of community paramedics out there these days, probably. where they travel around with a mental health specialist from Journey Mental Health. And then in this situation as well, we fit in very well simply because we have the medical ability to deal with an overdose if we happen to come across one. We carry the minimum, I would say, of materials to reverse an overdose that might happen in front of us. And I guess the idea too is, let's see, uh, you know, I think just having us, as Tom was saying too, it's like for people to see us involved in a program like this, it says a lot about the interest of this community, and to say that, yes, it's not all an impersonal, take care of the moment, take care of the problem now and ship you off to a hospital and forget about it. We are involved, and we do like to know that we have an impact and that we can have a greater impact by being involved in a group like this. Yep. Some of my personal interests are that I did work in an ER for about 10 years, and I've worked on an ambulance for 14 years now. And I personally also have some family connection to overdose and, mental health needs that probably every family is related to. Something that I also try and emphasize with people we meet is that mental health care and substance use health care needs to be just simply considered as part of the general health care for everyone these days. Stigma is what keeps most people, as I'm sure you guys are all aware of, stigma is what keeps people away from seeking the help. And if we can erase that little by little in any way, that's just something that people need to know, and that we need to start performing medicine in a different way, and that it includes all of these other problems. And I'll stop right there. You can go back to Lana.
Yeah, hi. I am Lana Hamilton. I am just one of the peer supports on this team. Our other peer support is not feeling well today, but his name is Joel Grunder. And so what I do is offer lived experience to this team. And a little bit about me is I work as a CCS peer support. I also work in the ED to recovery program. So I go into the ED when they call us to that the person invites us to offer some support. I also work in the jail to recovery, so I go into the jails, and I am part of the pregnancy to recovery program where I'm a doula, and then I'm the team lead for the art team. And I really like this going out into the community. Sometimes I feel a certain way, but always once, on my way back in, I'm feeling very good about our team and proud of what we do. At first, I didn't know if we were going to have a good response, and I believe we do. I believe that if there are people that have some kind of a preconceived notion about a police officer, once they see Tom and Tom opens his mouth, that's squashed. I mean, I witness it. And then, with Seth as the paramedic. And I think that they thank us, for caring. And we try to be as private. We try to use discretion as much as we can. Like going in quietly. But my role is to be the peer support, be the one that can look at this person and say, I have lived experience. I know a little bit about some things. And also I can pair up with these people as a MARI participant. So I've worked with a lot of people, and I'm still working with one. I'm working with two right now in the MARI program. And it is really awesome to see the lives change. I mean, all the other programs as well, but like I have some real special people that have graduated from MARI. So I'm primarily the one that is doing most of the talking after we have the introductions. And I'm also, I'm that face of hope. Like I know what it's like to have no hope and be in that dark place where you don't want to continue. And we just met one yesterday. I could see that when he was eager to connect, he's like, I want to get out of this, I want to change my life. And then to be able to say that you can and really know that a person can, is that that missing piece of hope. Like, I know how it is for me when I see a person that have been through some things, and when they say, well, I did it, it changes everything. So I really like our team, and I like what we do. I don't think we're that well known in the community, but I think we will as time goes on. Yeah.
Lana, thank you so much. And for Lana and Seth, as Tom and I kind of continue through the next few slides, feel free to chime in if there are things that I forget or things that you would like to add. So we talked through Seth's slide. We're just going to go to some statistics now, and I'll turn it back over to Tom to talk a little bit. And the statistics, as he referenced earlier, they're quite recent. They're from the research team that is an arm of this grant as well. And the statistics run through the end of November 2022.
Yeah, so as you can see, pulling from kind of that pool of either self-referrals or the algorithm or the EMS run reports to 348 people that we've been out and been able to visit in the community too. I think one of the things that was surprising for us as a team was how frequently we would find collateral contacts, family members, loved ones, roommates, people that are kind of living step by step alongside the folks in active addiction too. And I think one of our takeaways has been just how valuable that potential team interaction with those folks can be too, to let them know what's out there for resource in the community, leave naloxone with them, whatever it may be, and potentially connect them with some family support through safe communities. I think that's become a pretty interesting takeaway from us too, is that even if we don't find that person that we're set out to look for, to the impact of kind of communicating with people in that close circle. So 143 people that were collateral contacts. And as it says there too, a lot of times parents or potentially somebody that even witnessed an overdose incident or something like that too. And then 106 individuals that we've been able to give Narcan out to. We have the naloxone that comes with 2 doses in a box too. So oftentimes we'll just leave behind the box with the 2 doses. We've recently been able to start handing out some fentanyl test kits as well, so that people are able to access that and use it. And then we do have our partners at Safe have some safer use kits that we're able to get out to people in the community as well. And actually just yesterday, I think we handed out at least 3 of the fentanyl test kits now too, which our biggest challenge is remembering we have them and then telling people we have them. So then people are pretty readily willing to take them, but we just also have to remember we're pretty good about the naloxone. Since the test strips are newer to us, we got to get on ourselves to remember to present those to folks.
Tom, do you mind on this slide? I forgot to make a note. Do you mind speaking to that we've had individuals who've been revived with Narcan that the team has given out?
Oh yeah. I remember one instance where we met with an individual and a collateral contact, his mom, and we're able to leave some naloxone behind at the family home there too. This individual experienced another overdose incident. Mom used the naloxone that we had left behind as a means to help in reviving him. And I guess kind of the other neat part of it too is it's kind of all the elements came together. This individual was MARI program eligible. We got him enrolled in that pre-arrest diversion too, through basically our contact at the Addiction Resource Team visit. He successfully completed the MARI program. So there were 2 separate, what would have been felony charges that he was able to take that treatment and recovery course and make basically go away. And then the element of kind of supporting family too with the Addiction Resource Team visit. So I think that has been our vision, is how do we bring all those supports together to kind of handle the criminal justice end of it too. And a lot of times now with the MARI aspect, what it's opened up for us is at the end of that criminal investigation, if there is probable cause, we can write it up. We can leave folks in the appropriate environment. We can leave them in a hospital or medical care environment too. So that can be their primary need being addressed there. And then we say, hey, we'll handle this other part of it later. And here's some options for which you can do that.
Yeah, so I raised my hand. I suppose I could take it down now because I just wanted to add, like, if people have, an opinion that, yeah, you helped save my life, but then you turned around and gave me a ticket, it balances it out when we're able to give Narcan and fentanyl test strips and the number for never use alone, because it validates the fact that we just truly care. The harm reduction piece is really big, and I always see people's face light up when we have that to offer. So I wanted to add that.
Okay, can you see my video? I got punch happy there. My apologies. Lana, thank you for chiming in. If you saw me laughing, it was because I was musing on the fact that I always miss raised hands. So if anyone else had a raised hand so far, I apologize and we will take your questions. I wanted to speak to this slide because what Tom and I find is, at least in some of the police audiences that we talk to and in the community, a very frequent question that we get is, why is this a police thing? Why is MPD choosing to take part in something that has this many stakeholders and this much money, and it takes this amount of years to be immersed in the work? And this is the synthesis of our answer. I want to point out the bullet point on top. We're already there. And this is a really important piece because law enforcement is one of the very few 24/7 service agencies. If you call us at 2 a.m. on Christmas Day, we will come. We're already going to calls in which there could be a substance use nexus. Some of those calls include vehicle accidents in which someone has used, a whole variety of theft cases, theft by virtue of employment, theft of packages, misappropriation of identity, things of that nature, overdose calls. We see things, MPD sees things like child neglect cases in which children have been left alone or with an inappropriate adult because parents are in active addiction and need to go out to not be ill. Check persons calls, many, many more. So one of the points that I always like to emphasize is we're already there. So positionality wise, MPD and police in general, first responders, are in a significant position in which we're at the forefront of being able to offer resources and connection. Now going to the bottom right of the screen, Tom Coyne said this last week, and it just resonated with me, and it continues to resonate. This idea of shifting very consciously from an enforcement lens, which people think of when they think of traditional policing roles, to a resource connection lens. And that's something that this team is able to do by virtue of follow-up to calls that have already occurred, or in some capacity, being able to respond as a quick response team to things that are unfolding in the field. Then the last thing I wanted to highlight was, at least at Madison, we have this real commitment to the co-responder model. So for example, we have a mental health unit and a mental health team that has been using a co-responder model since 2016. That model is quite familiar to the community, that if there's a mental health crisis, there may be an MPD mental health officer, we have 6, and a co-responder from Journey Mental Health who go out together to try to problem solve and find the best resolution for that person, to preserve their dignity, to take them to a space that's the least restrictive and can best address whatever crisis they're facing. This is in the same spirit of that we feel like we're already out in the field. MPD is responding to calls and serving people who are in active addiction. How can we do that better? And it's through a team like this, a multidisciplinary team. So looking ahead, just this month, we have one of the busiest months that I can think of since the grant kicked off. So today, actually this afternoon, Tom is going to be taping a commercial about the Mari Criminal Diversion Program because, as Lana alluded to earlier, many in the community don't know about this team or this program. And Part of that is because we were stood up in 2020 and there was a tremendous amount going on in our community and the national landscape in 2020. So we're always trying to get more exposure and to let other community members and community orgs know about the work that we're doing and who we're trying to touch and how to access us. Next week, we have an opportunity to present at PARI, which is Police Assisted Addiction and Recovery Initiative. They're a national organization, and they put together a convening of Wisconsin police sites who are involved either in COSAP grants, which we're under, or who are looking to have a grant-funded type initiative. Then next week, we're hosting another Wisconsin Police Department to do site-based lateral learning. And at the end of this month, we're going to be attending a quick response team summit in Ohio. The reason we're going all the way to Ohio is, at least in Wisconsin, we're one, if not the only team of this structure. There isn't anyone that we can laterally learn with in Wisconsin, but we hope that that is changing soon. Then beyond January, a major initiative of ours is expanding our Mari Criminal Diversion Program to some of the bedroom communities around Madison who have interest in it, but don't yet have it. And I wanted to end on this note that there is always so much more that we want to do, and any individual team member can probably rattle off on two hands and far beyond things that they would like to do in spaces they would like to get into. We're one team and we're only a few people, but we have big ideas and big hopes. A few of the spaces that, just from my lens, that I have hoped we can work toward is getting some contacts in the Madison faith-based community. We would love to know some pastors at the churches so that they can put forth the ART's number and put forth information about safe communities and how to access resources, because this is so stigmatizing, as Seth talked about earlier. And of course, in a perfect world, we would love to have more capacity to respond in real time, but there's only so many hours in the day and so many opportunities for that. The reason that this team was stood up to work noon to 8 p.m. is a several year study in Madison showed that that was the peak window if you looked at distinct 8-hour periods in which overdoses were most likely to occur. That's helpful, but anytime you have a data set, it immediately becomes less relevant as more months and years go on. So overdoses occur at all times of day, but it was very intentional to have the team work noon to 8 to try to address as many in real time as we have capacity to. And then very specific to Madison, we want to have a training refresher. We have 500 officers at Madison spread across 7 different buildings. We're becoming a bigger police department, and just in the last 3 years, we've hired over 150 new officers. So we're kind of in this tremendous period of new officers, lots of retirement, and with new young officers is the opportunity to connect with officers who are new to the field and are willing to accept and implement progressive programs like this.
Can I tack something onto the end of that thought?
Yes.
What I found interesting too is as far as internally here from like a police culture standpoint, there's not a whole lot of sales pitch that goes with this. You get a lot of people that are coming through the door here that wanna, you ask anybody, why do you want to get into this? Do you want to help people? A lot of times you get into areas where you feel like, am I really helping? These are efforts that actually you feel like you're seeing some opportunity for folks too. So I think it's been fairly easy, especially as we get new people in the door and even people that have been here for a while too, just to reinforce the values behind it. We've had the opportunity to get the addiction resource team in front of our recruit academies, and you can hear a pin drop when our peers share their stories with the people in the room. And I always ask them at the end, I'm like, what I want for you to remember is remember Lana's face and story when you're out there. Remember whatever's being shared with you now. So as you get into kind of that cycle of what can be patrol services life and you feel like you're running all over the place, the idea that I tell people at the end of Mari all the time too, I'm like, we need this victory too. We want this win along with you too, because it reminds us that maybe we're a small part in some work that's helped you get to a better spot. And I think anything that's a pilot, I would say we're not going to say we're any subject matter experts. We have some incredibly talented and caring people on this team that want to get out and make a difference. And every now and then we hit these moments where like, oh, maybe we know a little bit more than we thought. Where I was going to share just another short story about, we went to an active patrol call, police responding officers, fire department, paramedics were already on scene. We let those initial first responders take care of resuscitation efforts and initial like steps in investigation. And then we kind of found our way into that space where we were able to talk to this individual's grandmother to leave her with some information on resource, leave behind some naloxone, proceeded to the hospital where this individual was taken after the overdose incident. We're able to have a conversation with him and could basically on the Mari end of it do a right there in the moment vetting. And I sat there with the responding patrol officer and this individual and made that Mari phone call to get engaged in the program right there. So for me, that's kind of the perfect storm of all the elements of the team are doing what we want them to do and intend them to do. And also it for this individual, great success story for us too. Kind of made some pretty big changes in his life. Embraced that full 6 months of recovery support, and I think is still in contact with one of our peers, and then just some big physical fitness goals and stuff too that added on to that positive progression for him too. So I think we're happy to be able to look back at some of those, and even at moments where we feel like we're going into this uncharted territory, having positive outcomes or results like that obviously is helpful.
Thank you for chiming in on that. The last slide, which I'll go to in just a moment, is our contact information. And I put Tom and I down, but we are a great conduit to the rest of our team. So if you want to connect with someone from Safe Communities, Lana, or the rest of the team, or their supervisor, or Seth, or the chief who oversees him at the fire department, I would be happy to make that happen. Something that I do want to reflect on, because MPD gets asked this, is like, what skin in the game do you have? Why do police want to do this work? And everyone has their own unique and different answer. But I want to share with you a call that I had when I was in the field as a patrol officer. I loved working patrol. I did it for 11 years before I moved into the role that I'm currently in. And I went to a threats complaint at the Howard Johnson Motel on the east side, which is where I worked. And I talked to a young woman who she just struck me. I don't know if it's because we were close in age at the time or if there was something that really struck a chord with me, and I spent quite a bit of time with her. She was dealing with active addiction. She had fallen into heroin use, and she had called police that day because her dealer had showed up and threatened her with a gun. And she was sort of vacillating between, I need you to help, but I really don't want to talk to police. I feel like you guys always get me in trouble, but I'm in fear for my life. And some of the options that I tried with her that day was to get her get her connected with the victim response. The crime. I'm trying to think of the subcategory of the DA's office. It's within victim witness, but it's the crime response unit, and they work with people who are at heightened risk of like significant bodily harm or death because of circumstances in their life. Some of the things that can be done are like hotel rooms under fake names and extensive safety planning, and she wasn't interested in that. And because of her reluctance to provide a whole lot of information, we couldn't identify the person, and I didn't have charges, but I really wanted to do more for her. And I think about her often, and I wish that we had a Mari program and an ART then, because where this story ends is 2 weeks later, she was shot and killed by a man over a $20 drug debt. And I can't go to the east side of town without thinking about her face, her name. She stays with me. And every cop has a different why. But that is, for me, to be very succinct, that's my skin in the game, because we serve people on different calls in different ways in which we're not able to connect them with the things that they need. And I hope that we're able to meet and connect people like her, I want to be careful to not use her name, with recovery resources that could positively impact their life and take them to an end and an eventuality that isn't the one that this young woman suffered. So I put up on the screen how to get in touch with us, but this is also the point in which we would really welcome any question that you have for any member of our team. I am going to leave this up here for a few moments before I stop screen sharing, and I saw that I received a chat, so I'll take a look at that and see if there was a question from the chat.
So much for the presentation on program there. I think the one that was in the chat, we had a little bit of the dialogue box in front of the slide for a little bit was all that was. I'm not seeing questions quite yet, but any questions, comments that the folks attending have?
I'll just give a comment. This is Caitlin with the UW Health Hub and Spoke program, and I actually got to see a patient graduate from Mari once. It's pretty cool. We met at Safe Communities, and I believe your officers gave him back the tickets that were written. So very cool. Thanks for all you do.
Once again, Tom was helping me navigate my technology, but we heard that, and thank you so much for sharing that. That is incredibly powerful to hear. Did you want to, I didn't mean to speak for you. Go ahead.
No, it's just always like I feel like an incredibly positive experience too. And I always, when we go out to meet folks as the addiction resource team for like MARA graduations too, just that idea of, I think we're fortunate that a lot of times the peer that's worked with them over that time period can make it to that celebration as well too, because they've done a lot of the heavy lifting along with that individual. And I think it's something, there's a huge positive in my sense, through my perspective of if police officers are going to be who you're going to see potentially on the front end of this, that value of saying, hey, we want to be here to celebrate your achievement and success on the back end of it too, which I think kind of levels stuff out. And it's just cool to see where people arrive too at the end of the program. So thank you for sharing that, Caitlin.
I would like to add something quick to that. I come from a place of gratitude because I was one of the people that was revived, and 4 different times in the community in 2017. So we do get it. Not everyone, but some of us do. And being out in that car and knowing how many calls come over is shocking to me. But I'm the face of a person that was revived, and also the area that we go out in is where I kind of ran. So I'm really grateful that, and I also want to say, Dr. Brown, I was one of your patients way back for Suboxone, but sometimes it takes a long time, but sometimes we get it. Sometimes quicker, but yeah, I'm really grateful for the Madison Police Department and the fire department, because I don't think I would be here. And my family is very happy that I am. And I am too.
And we are too.
Question did come up now in the chat, wondering about the most common referrals that your team makes in the community. I think you mentioned Tellurian is one, but wonder if there might be others. And then if you've run into any challenges with those connections for people that don't have phones.
Yeah, so in regards to what was the most commonly given referral, I know we have Janae, who's our principal investigator from the research team. So I may see if she wants to speak to that. Otherwise, Tom can probably chime in. Janae, are you still on the call?
I am, yes. Thank you. Hi, everyone. Janae Goodrich with the UW Population Health Institute, and we are partners in research, evaluation, and data collection. And the ART makes a whole host of referrals to things that include housing, food support. I would say their most common referrals are to safe communities for peer coaching, also to Tellurian and the Behavioral Health Resource Center for assessment and further connection to services, and to some of the local treatment providers like Monarch, Journey Mental Health, and some of the other treatment providers there. And then I'll let you all speak to how those connections work for people who don't have a phone.
Thanks, Janae. And I'll turn it over to Tom to talk about trying to serve folks who don't have a working phone or whose phone is intermittently on or not working.
And I kind of want to just share, I guess I'll look at it as a historical, where the first version of MARI, for when people had criminal justice system interactions and there were charges and we wanted to have them do that as a route for pre-arrest diversion. It was a pretty rigid time window of, you need to call this number within this amount of days to start the process. And we found that that's obviously not going to fit not everybody's a 9 to 5 Monday through Friday world. Not everybody has a working phone too. So we've tried to switch around, I guess, some of the sequencing or the parts of that too, to try and make it closer to a one-stop shop for entry into that program. And the idea being, if we can get an initial connection with somebody either by phone or in person with the program partners at Tellurian so they can start that assessment. We're trying to do that all in one visit. So we're not playing that phone tag game of, hey, call, and then we'll call you back to set up an appointment. And then, because I mean, a week's worth of time can be a world of change, I think, in somebody's life too, especially the folks that we're trying to reach in the community. So we've tried to just provide more direct connection with that as well. One of the discussion points was at one point seeking out if there was like funding to actually do like leave behind phones for people in the community to discuss, but didn't come to fruition at this point. The other thing that, and sorry, I don't want to talk in your place, Lana, but the idea of if we can connect people to our peers and then if there's transportation issues or other logistical challenges, would you mind speaking to that a little bit, Lana?
Yes, that is a huge barrier that we break by picking, providing transportation from wherever they need it to be picked up. I have helped a few people get connected with a phone. And there's a lot more resources that I can connect a person to. But yeah, that's a big thing that they say, I don't have any transportation. Well, we do. So.
Seth, can I put you on the spot too for just a second? I know we discussed a little bit the idea of the frequency with which you're seeing people like with EMS run stuff, just provide like checking that box so that info comes into you. Would you mind just talking about that a little bit? Because I look at that too as an idea of that breaks down another barrier where, as opposed to, potentially historically what that's looked like, the more our police, the more our paramedics are thinking about, hey, what's another follow-up opportunity?
Absolutely. Yeah, it is one of it's kind of very difficult to have all of the information in one place at once, but we find if we kind of combine, well, I have a little information here, they might have a little information there. We actually can figure out a name, a place to contact somebody, and a little more information about their situation. We of course had to deal with the barriers that HIPAA provided right off the bat. We worked at getting permission to kind of share our information amongst each other, and by sharing our information, we share very specific stuff that is related only to the substance use of someone, and in a sense that falls under the area of it is a matter of potential loss of life and limb, and therefore we can break that HIPAA protection in that instance. So we often work together to kind of formulate a list. We do in our patient care reports have a box that the paramedics can click, and what that means is that they are saying this person could use almost like an outreach that they qualify for narcotics bridge to help. It's I guess it's always about education, and our people too. We have 400 and maybe 50 firefighters and paramedics out there. Not all of them know about this program, and one by one we're trying to inform them that they can start that conversation in the ambulance if they have the opportunity. They can, if someone agrees to say, yeah, they'd like to hear from our group, that's permission for us to go out and find these people and hopefully provide them, that little bit more of a bridge. Dropping people off is clearly not the only solution to solving these problems. So we're all working together, and hopefully our team as well can branch out into other EMS municipalities throughout the county, not just Madison, and really have a more blanket connection with people throughout the county. Any other questions?
So Seth and team, going on with that data sharing, there is a question from Allison in the chat. Is there any way to get communication as a healthcare provider if a patient is enrolled in MARI?
I think that's a deeper question that is almost probably done on an individual basis. Sometimes people are like actively part of a care plan where that kind of sharing happens without difficulty. I think we do try and, as others were saying earlier, we try and definitely maintain a person's privacy and let them be the guide of to what limit they want to be involved with us. I think, as far as us saying to a provider, say at the UW, that, maybe they've lost touch with someone and can we reach out to them? We might try and do that, but it's up to that individual to reach out to their provider, and that's a fine tightrope that we have to walk. In fact, like that. Yeah, I think. Hope that answers.
Seth, I'm going to add to that as well. I was just thinking, and I should have invited to this forum, Kimberly Hill is the clinical assessor at the Treatment Readiness Center at Tellurian. And I know she would be able to speak knowledgeably to that question, and she's not here. So I would be happy to reach out to her and ask if any of the assessment that she conducts with potential MARI candidates covers information sharing with primary healthcare providers, but I don't know that immediately, and it's an excellent question. I did see there was one additional question too about do you engage individuals with alcohol use disorders and services? So I'll let Lana, if you will, speak to Safe Communities' aptitude to do that for the ART, because our grant is specific to so it's comprehensive opioid, stimulant, and substance abuse. It does not encompass alcohol. So if we have individuals who MPD, for example, have contact with and are arrested, let's use theft as an example, where it's driven by their use of alcohol, we would not be able to divert that person into MARI.
But they can be referred to us, and alcohol is a drug, so we cover all, and we also have programs that are specific to alcohol only. There's a Tula app, and there's the OWI court. But whatever anyone wants to change into the positive is what they do. It's all self-directed. And I was going to bring this up too, that if we go into a situation and we can see that this person is not interested, we retreat, we back off. We do not want to be intrusive, and we do not want to tell them what they need to do. We're there to offer. So
just quickly going in order, I see that there's a question about, is there follow-up with reports of, is it fentanyl added to other opioids? Is that what the question is driving at? I just want to make sure.
Yeah, just wondering if there's follow-up, around that sort of supply, if there's fentanyl in sort of supply at a particular point of call, unless Dr. Boosting, you want to clarify that?
That's what I meant. If there's positive fentanyl, I think those are associated with much higher risk of overdose and death. So, like if a person's given those strips, they say, oh yeah, this is positive, I'm not going to use it. But then is there a place where they can report that and have some kind of action to look at removing that from as a source?
We have not gotten that question before, so I'm glad that you posed it. One thing that I want to mention is, at least at the police department, for all of us, right, as service providers, the topic of fentanyl is a huge one. And I know that our data analyst, Kelly, I know she got a question just in the last few weeks about how many reported overdoses in Madison had a fentanyl connection just recently. So we do track that. And I know that in the past, MPD has worked with public health. I say in the past because our primary point of contact left there. It was Sarah Johnson. And I don't know that we have a continuing point of contact that we liaise with for things like overdose spike alerts and things of that nature. And then in addition, I just wanted to mention, in addition to our work group, which is very much diversion and deflection, as we've talked about, there is a separate law enforcement work group, which is the task force, the Dane County Narcotics and Gang Task Force. They also very closely track trends in overdose and fentanyl. So we are not, as you can imagine, we're not in super close contact with them because we're fulfilling such different purposes. The folks who work in task force are very much looking at dealers and enforcement, and we are very much looking to engage with people who are in active addiction, not people who are dealing drugs. But we would share information back and forth on things like that. So if the task force were to notice this a spike in, let's say on the north side of Madison, fatal overdoses with a fentanyl nexus, they would share that with us and vice versa. So I wanted to provide a little bit of background info, but I don't know in regards to follow-up, if an individual uses a test strip, it tests positive, then with what they should do with the product that they have. And I would invite anyone else who has information on that if they want to answer.
Can I add on to your thought too
Please do.
about those kind of parallel worlds, I guess, with the County Narcotics Task Force? They're looking at people on a distribution level. So if they're seeing trends where there's fentanyl or just opioid coming in through a source, a lot of times their focus is apprehending that individual, stopping that distribution. I will say though that they've been really good about if they come in contact with person A and that's who they believe is bringing this product into the community, but person B also has a small quantity and they might be MARI eligible too, they'll send those folks my way or MARI's way too, which I think is a pretty good working relationship where they continue to get their focus on bigger distribution angle, and people that are kind of wrapped into that can also still get a look at criminal diversion.
I was going to add to this as well in the sense that I guess you maybe mentioned that if someone uses the fentanyl strips and they realize that fentanyl is in a product, that they might not use it or they might want someone in trouble. The truth is they probably will use it anyhow. And our hope for them having the fentanyl strips, maybe this makes sense, is that they know it's in there and they can therefore hopefully use less and go into it with a better idea. We often say this in the group too to people we meet. It's like, we know very well that there's fentanyl in absolutely everything these days, from marijuana to, I mean, it literally shows up in every single substance you could buy. So really, what we're trying to do is get people aware of the fact that it is in everything. If they detect it, maybe it's not so much that they're going to report it or they're not going to use that substance, but that they should use it with extreme caution.
Just quickly add, in some harm reduction circles, they basically advise if you purchased an opioid such as heroin, basically assume that fentanyl is there, but where the test strips may have more utility for non-opioid or things being marketed as non-opioid substances like methamphetamine, cocaine, whatever.
Yeah, and we're seeing just anecdotally out in the community people that are saying, I bought crack cocaine and then fentanyl tied into that too, and they experience what's overdose symptoms. And it's been interesting too, and I can't put numbers behind this, but I can just put as far as interacting with people. You're seeing some of those like different substances, like methamphetamine hadn't been real big, it felt like, for a while, and some of that stuff's creeping back into the community. And I'm curious as to if people are just what you're describing, thinking, okay, anything that might have an opioid, we have to at least work on the presumption that it has fentanyl. Let's look at other options. So we're seeing some other stuff come back around that feels like it hadn't been here in a while.
So I'm aware we're coming up on the end of our hour, and I don't mean to keep you beyond the time that people have committed. So please stop me if we need to stop. I did see one more question about asking what is the difference between MARI and drug court. There's a whole bunch of different layers to it, but I'll just try to synthesize. MARI is very much an early intercept light touch program. We find looking back to data from 2017 when we had the first iteration of MARI that ran from 2017 to 2020. What we find is MARI works best for people who've had limited or no contact with the criminal justice system. And here's what I mean by that. If you have an individual who experienced an overdose and they were charged with possession of heroin, but they've never been charged with anything before, there's someone who's working and has a family and really are looking to avoid that CCAP entry and the negative impacts of employers and others finding out about this pending charge, we tend to have success with folks who more closely fit that criteria than perhaps someone who MPD contacts for the same set of circumstances and overdose. They're going to be charged with possession of heroin, but they have 10 open criminal cases. For that person, there might be a lot less impetus or incentive to try to complete a program to avoid a CCAP entry. Obviously, I would never try to put into words individual motivations of when people are ready for recovery, when they're at the point in which, the tipping point in which they're ready to seek that, because that's so individual. But we know that MARI works best for people who've had very limited or no interaction with the criminal justice system. And we are a model that does not involve a ton of monitoring. They get the most, MARI participants get the most contact from their peer. Their peer is a mechanism of support and is not oversight. Drug court is much more intensive oversight, requiring regular testing and check-ins, and it's much more stringent, and there are a lot more parameters to it. Also, drug court might be available and a good option for someone who is charged with offenses including drugs, but also including other things. Like one example is we cannot have a MARI participant who is charged with possession of heroin and child neglect, because child neglect isn't an eligible charge. So that might be circumstantially something that would be a great fit for MARI, but we can't accept it because of the non-qualifying criminal charge. That might be a good fit for drug court if the ADA thinks that the person's need would fit that kind of system. Lana, I know you have had great insights on MARI and drug court, so please chime in if you'd like to add anything.
I think you did wonderful, you know. And somebody did write in here, the biggest thing that stands out for me is that in MARI, the charge doesn't get to CCAP at all. So it just stays on Tom's desk. That's how we're able to connect with them and let them rip it up when they complete. And drug court is actually the program that saved my life. And some people need more supervision and more support like that. So like we don't give people UAs, we don't monitor them. It's just support and moving their life into a more positive direction.
Thanks, Lana.